want to thank Paragonix for putting on this symposium. There's clearly remains a lot of interest in this technology and this topic. I sort of thought of this as the least exciting topic, but cost is really the information I think people want. Does it make sense to use this device to add expense to what already is a pretty expensive endeavor? So we attempted to do that with a cost analysis, and we used the GUARDIAN Registry. And I want to just point out Andreas is being a champion of that registry and how important that has been, because at an individual center, you need a really big center like yours to be able to figure that out, whether this is a step forward, because practices change and the temporal relationships change. So outside of that, these registries are super important, and as more and more data goes into the registry, the answers become, I think, clearer. So we need more data in there. If those of you that are using the device or looking to use the device, we invite more participation in the registry, and we hope to get a lot more science out of the registry. So my first several slides are really background. They're a lot less prettier than Jeff's, but I'll go through them anyway. You all know that the organ allocation system has changed in 2018, and the reasons being, of course, to increase regional sharing, to provide access to organs for those most at risk of dying. And what that did, looking at the report in the first year, is, of course, it gave us a lot less access to organs in our own DSAs, and we had to travel further, about twice as far in Zone A, which is more than 500 nautical miles, and 3 times more often in Zone B, which is 500 to 1,000 nautical miles. And looking at that, what that did to travel distances, we're all traveling further to get the organs, as you know. And in that right-hand panel there, you see that it's translated into a longer ischemic time. That's 13% on average longer, but you can see a lot, fewer hearts in that sort of less than 3-hour time window. And we know that those types of hearts and patients do quite well. This is really interesting data. That's looking at each of those dots is a transplant center, and those are colored by year there, 2018 in black, 2020, 21 in blue. And it looks at variance in the change in longer ischemic times, defined here as greater than 3 hours, and changed in volume at each transplant center. And what you see is that linear relationship where centers that are doing more transplants are doing it by doing transplants with longer ischemic times. If you're not doing longer ischemic times, then your program is shrinking. And so we're all sort of interested in growing our programs. In order to do that, you have to go further to get organs, as Jeff has just shown you. And most of us are familiar with this publication by Kilich in 2021. And that just sort of highlighted some of the important changes that we've seen in the practice of transplant. We're transplanting more people off acute mechanical circulatory support, mostly balloon pumps, but also ECMO, much further distances. And concerningly, in that early analysis, we saw a decrement in patient survival. Now, it does appear that that's not been borne out in more recent data, and that's nice to see that we've learned how to operate within this new system so it doesn't come as such a mortality cost. But there are a lot of individual center reports that are showing higher rates of PGD, and of course that can translate into worse long-term outcomes. Just what's happened in Massachusetts, similar to other places, we're getting a lot more organs outside our region, a lot less access to organs within our region, and showing that data just a little bit differently. Going from 2018 to 2021, you can see that more than 50% of our organs now are coming, that's just at our program, are coming from more than 500 nautical miles away. So again, the risk profile of our patients has changed over time with that allocation change. So the big question is there new technology that we can apply that can mitigate some of that risk and help us improve our results? And is it cost effective to utilize it? So, as you know, for 50 years, we've been using essentially a beer cooler. And when last I checked on Amazon, they made me take it out of the slide, but the beer cooler was $150. And that's for a pretty nice one. That's substantially more than $150, but it's also got a lot more technology applied to it. So we attempted to answer the question using the GUARDIAN Registry. The registry data I'm going to show you is a little bit different than what you saw earlier, because we did this earlier in the year and we stopped the data in November 2021. These are the investigators that contributed patients. We looked at 10 centers, and we captured, using Medicare cost reports and hospital charge master reports, the major components of cost associated with an index hospitalization for a heart transplant. And as you see, there's some variability in those buckets across institutions, but they're mainly similar. And the big ticket items, again, as you would expect, are ICU stays, floor stays, and especially the application of mechanical circulatory support, which is this one. So that's the big one. There's a lot of also physician and other charges associated with that. So again, to try to make these groups comparable, we did some propensity matching to try to remove confounding covariates, and we ended up with two pretty well-matched cohorts of just under 90 patients. You can see that they're well-matched with respect to size, age, sex, and sex mismatching. Slightly higher sex mismatching in the ICE group, but less female to male in that group as well. The recipient characteristics also quite similar with respect to most of those baseline characteristics. You'll see that the ischemic time is slightly longer in the Sherpa group, and both on average more than 3 hours. So when I show you the outcomes data, remember that this is not a all-comers population. This is a population of patients that are on the longer side of ischemic time overall. Postoperative outcomes, similar in a lot of things. What stands out the most is the need for mechanical circulatory support, quite high in total in the ICE group. ECMO and VAD was 26.4% versus only 8%, and that translates into a severe PGD rate that was similarly considerably higher in the ICE group, and that did achieve statistical significance. Inotrope score, interestingly, not too different. Length of stay and discharge outcomes. We've seen this often when we slice this data up. You tend to see the ICU and the hospital length of stay being a little bit shorter. But the survival has been, was trending towards improved at the time of this analysis. As you just saw, it has now achieved statistical significance in the latest data draw. When you look at cost, there was no significant difference with respect to cost. If you just look at ICU stay and regular room stay, that's probably because of small numbers, but you can see that the trend is towards increased cost, and that's just because of the longer duration of stay. The big cost savings there is in the application of MCS. You can see it's, of course, much more costly because it's used more often. And when you take these totals in aggregate, you can see a significant cost savings when the Sherpa pack is used, and that's shown differently up here. And of course, the majority of that cost we see in the reduction of PGD, and if you can reduce that, it saves a lot of money. So just to conclude, the new allocation system has resulted, of course, in longer travel times and longer ischemic times. There's certainly a fair amount of data that there's higher observed PGD as well. It appears that the use of the Sherpa in the U.S. is clinically and cost beneficial as a donor heart preservation system versus ICE. The average cost was about $26,000 per patient, which is substantial. And if this data held true across the whole country and everybody was using it, that could be a significant amount of money that we could save switching to this type of a technology. You know, before I end, I'm sure there's a lot of skeptics in the audience. I have been a big skeptic of this technology. When we started using it, we were not having problems with PGD. Our outcomes were good. That frozen RV never really bothered me, to be honest. It softens up pretty quickly. I thought it was worth looking at. It was intriguing, and we started using it. I was really happy that Andreas, you know, convinced me that the GUARDIAN Registry was something that we ought to participate in. And as we started to look at the data, we started to see very real differences. And you can sort of, you know, push them aside and explain them away. But the more data that gets in there, the bigger those differences are. And so people will often call me because they know I use it, and they'll say, you know, it's expensive, you know, how can we afford to use it? And, you know, if the data continues to move in this direction, at some point the answer is going to be, how can you afford not to use it? It seems to make a very real difference. And at this point, I do believe in it, and I certainly agree that we should continue to collect data, because that's important. And there's, the data that we have is not perfect. It's not randomized data, but I'm not sure we're going to get there at this point because a lot of us are probably not willing to randomize, and the patients that that you'd most expect will benefit from it. So are we doing panel discussion now? Thank you all for your attention.